billion patients with one of our products. So this is more than any other pharmaceutical company in the world. And this shows you about the breadth of this company, Novartis. Here we go. So Novartis belongs to the 25 largest companies by market capitalization. So if you have an interest in buying Novartis, you have to spend at least $200 billion. And it belongs to the most respected companies globally as well. The key figures are shown over here. So we have 138,000 employees across the world. We have a net sales of about $58 billion, and 23 or 22% of it we reinvest into research and development, because we strongly believe that innovation is key to existing this market for the future. Novartis is a relatively new company, has been founded or created in 1996, but there is a large history behind. So the result of a merger of two companies, Ciba-Geigy and Sandoz, led to the company, or created the company Novartis. But Ciba-Geigy itself is the product of a merger of two companies, Geigy and Ciba, while Geigy history goes back to the year 758. So there's quite a lot of history. The name Novartis comes from Latin and can be translated in Novartis or new skills. So this is just a rough overview of the main products we have. There are thousands of products available from Novartis. The most important ones for us economically are from the Novartis Pharma section. I hope you have never been in touch with those medications, because this is for life-threatening diseases, mainly for cancer. Maybe more common is the consumer health business, so Voltaren and Fenistil. And then we have a lot of vaccines to prevent diseases. And in the name of Alcon, we have summarized all activities around the eye care business, the ophthalmology business. But there's still a lot of things to do, because too many people still die from diseases. So 2 million people die each year from diseases which are preventable by vaccinations, and so this is something we have to overcome pretty soon. Another problem is that from infectious diarrhea, there's 1 in 5 child death worldwide, basically mainly in sub-Saharan Africa region. Mosquito-borne diseases kill still thousands of people, in particular children below the age of 5. And they don't have to die because we have medications. So the seasonal flu causes more than 250,000 deaths each year, and we still suffer from the common cold. So there's enough of things to do for us, for you, for the future. So before we build our strategy, we step back and look into what are the current trends in the healthcare segment. So the environment changed, or is in the process of changing. And what you see here in the slide, there is 3 very positive trends and 1 negative. And so the population is getting older, which is good. We have an increase in the middle class of emerging markets, and they would like to have access to good health care as well. And then on top of it, it comes a lot of advances in science and technology. So we discover new medications, but they're extremely expensive. So there's this challenging situation that there's, on one hand, that there's an increased demand of new therapeutics. On the other hand, it's the problem how to finance those. So our results, our strategy result is shown here. So we have subdivided the company portfolio in 5 different divisions. So with the pharmaceuticals, we provide innovative medicines. So this is the patent-protected medications. With Alcon, as I mentioned before, we support eye care, in particular the problem for elderly. Then we have with Sandoz and the consumer health care business, we provide affordable options and we support self-care. And last but not least, so the best medication is if you can prevent disease. So coordination business is in place to support this. So how research fits into it? Because I'm representing research, I'm part of this organization called NIBR, which stands for Novartis Institutes for Biomedical Research. So NIBR is an independent, so in short it's called NIBR. NIBR is an independent organization which supports all these the other divisions. And we have many sites around the world. And we're quite productive and quite good at finding new medications. So for example, in last year, we received 3 FDA breakthrough therapy designations, which is a record not only for us, but it's a record for all our competitors. So those are the 3 medications, which I will go into a bit more detail during my presentation. So in total, we are about 6,000 employees just in research, just in NIBR. And we have a headquarters in Cambridge, US. There's 3 other sites in the US, so 2 in the West Coast, in close to San Diego, La Jolla, and there's another site in Emeryville, in the Bay Area. And we do have 3 sites in Europe. The biggest site is in Basel, in Switzerland, 2,700 employees. There is 2 sites in Asia. The newest site is in Shanghai. And a very interesting site is here in Singapore. There's about 100 employees, and the focus of those is to combat diseases which are neglected. So neglected diseases like malaria, Chagas disease, dengue virus infection. So we know that we'll never get any profit from it, so we do this just to support people, in particular in the sub-Saharan Africa region. So how those 6,000 people are organized? They're organized in 2 main pillars. So one pillar, shown here on the left-hand side, is the core technology competency, like preclinical safety, translational medicine, genetics, assay development, and all the chemists are summarized in one group. The other pillar is the area of diseases. So this is where the biologists are working, which is the medicine. The MDs are working in. So they have this expertise in 3 main areas, which is, the first is autoimmunity and inflammation, cardiovascular and metabolic diseases like type 1 and type 2 diabetes. We have infectious diseases, we have diseases of the muscle and the bone, tendon and ligaments as well. We have a neuroscience department in Cambridge, US. The focus is here on diseases like Alzheimer's diseases, Huntington diseases, Fragile X, and so forth. In addition, we have the biggest group is working on oncology indications, oncological indications, cancer. We have the eye care ophthalmology group in the US, and then there's one small site which is currently in the UK, is a respiratory disease area. So here we go for asthma and COPD, so chronic obstructive pulmonary disease. But the main driver of research are the project teams. So the project teams are in charge to make the best out of these various sites. So the project team head is in charge of getting the right technology on the right time and brings the team together. So how will we select our project? Even though we have 6,000 employees, we have to focus. And the way we focus is shown here. It's a 2x2 grid, a very simple one. So we ask 2 simple questions. The first, is there an unmet medical need? If this answer is yes, and is there a high unmet medical need? And if you have, the second question is if you have an understanding of the disease mechanism, and if those answers are yes, then we embark on this and we go into this project. One example is shown here. This is a form of leukemia, so the cancer of the white blood cells, chronic myeloid leukemia. 10 years ago, this was death sentence. So if you come to your MD and he detects white blood cells like it's shown here, you have a life expectation of about 6 months. But then it was discovered what caused this disease, so the mode of action of the mechanism has been discovered. It's the rearrangement of 2 chromosomes. And this rearrangement forms a fusion gene, and these fusion genes produce a foreign protein. And this protein, it's a kinase, can be targeted. So this is what we have done. We have targeted this kinase, and develop the drug. And based on this medication, the patients are now have a chronic disease, from life-threatening into a chronic disease transfer. So this is a very famous drug for Novartis. It's called Trappe, has been on the market since 10 years. And the patients who first received the medication 10 years ago are still alive. So this is an example of Trappe. It's a rare case. So usually we have a lot of attrition on the way from the idea how to develop a therapy to the registration of new medicine. But usually we start with many compounds, many projects, and then you have down the road, you have a lot of attrition. So the number of compounds shrink, the number of targets or projects shrink up as well. In the end, you enter with 10 compounds into the clinic, and if you're lucky, so one new medicine is then registered. It's a long-lasting process, can lead about 14 years, and costs quite a lot of money. So $2 billion in average. The beginning of the phase is the cheapest one. As closer you come to the clinic and to the registration, it's more expensive it is. So it seems that this concept of the drug discovery process has been copied from Russian handcraft art. So I couldn't resist to showing this. Sorry. It seems that so where NIBR, so the research area, fits into it. It is the first part, let's say to the middle of it. So this is where research is active into. And a bit more detail. It starts with target discovery and validation of the target. And then it comes to the drug discovery process, so where we test the compounds and where we do the basic research into it. In the middle is the safety and drug metabolism testing, because we would like to have safe medication. And the final hurdle is the proof of concept. So we have to show that the original idea we have had, let's say, 5 to 7 years ago, really turns into truth, and we can cure or treat patients with this medication. And then we hand over to development, to the full development. So let's start with what is a target. A target is usually a molecule, a protein, which is, we believe, is causally related to the disease. So these are the most predominant target classes of today's drugs. Discovery is enzymes, kinases, proteases, ligases, things like that. Receptors like G protein coupled receptors with ion channels and nuclear receptors. These are the traditional drug targets. One of those examples is shown here. If you have a disease, it's a very rare disease, is a so-called Netherton syndrome. So this boy suffers from syndrome since he was born. This is a genetic mutation which leads to the overactivation of a protease. And this protease then defects the skin barrier. And the defective skin barrier is then let the skin open for allergens and pathogens, and then you have symptoms like this boy has. And we've developed a specific and selective inhibitor which targets these overactive protease and turns back and restore the skin barrier. So this is just one example. So how do we get those targets? So we have several ways for target validation. So one is a fundamental understanding like the renin-angiotensin system, which is well known since ages, or sometimes serendipity helps us on folk medicines, we just follow what is already known. But what Novartis is known for, the research is well known for, is the genetic information which is around, and link those genetic information to pathways. And I would like to go into this in a bit more detail. So if you have been on yesterday's keynote introduction lecture, so you have learned that in the human genome, which has been sequenced to the total 10 years ago, has 26,000 genes. With those genes, we can produce, our body can produce, 100,000 to, so this number is still not known, to more than 1 million different proteins. So it looks like that there's a big mess in our challenges, and it's one of our what we became very, very good at Novartis. We were the first company which has been embarked in this new way of the discovery drug targets, is targeting key nodes and develop drugs in those pathways. Even though there's so many proteins, there's only a couple of dozens of pathways responsible for disease. So one example of such a pathway is shown here. It's the insulin pathway. You know that insulin is responsible to regulate the blood sugar, but it's also a growth hormone. So this pathway, which is here activated, there's a key node in it, and this is called mTOR, the mammalian target of rapamycin. Rapamycin is a natural product. So this has been known. And what is also known to us is that the imbalance of this pathway caused many diseases. So what we have done, we have developed out of rapamycin a drug called everolimus, and this drug, because it's targeting this entire pathway, can then be used to treat many different diseases, all diseases which are impacted by imbalance of this pathway. So like multiple cancers, vascular proliferation, or solid organ transplantation. So this is the I would say, one part of our strategy to deconvolute the pathway, to build a drug which targets one key node in this pathway, and then outreach to many different diseases which are depending on this pathway. So if you don't have a natural product which we can optimize, so we have to find a good starting point for ourselves. How we can do it? We have, as other companies have, a large set of compounds in our archive. So for instance, Novartis has about 3 million compounds collected over the past 200 years. And in the anti-chemical space, if you would have all the compounds possible, it's 10 to the 62. It's a nonsense number. So nobody would have such numbers of compounds. What we have is representative selection of 3 million of compounds, and then we start to search for a good starting point. So this is called high throughput screening. So we test 1 million, 2 million compounds against a target, and we don't expect to get a drug out of it, but we get a starting point to build a structure-activity relationship SAR. And based on this, we can then optimize the hit into the lead, and from the lead into the medication. So for testing those compounds, we have a lot of technologies. I don't want to bore you with all these details, but I would like to show you one example. It is how we transfer the compounds from the original source into the assay plate. So this is the plate where the assay takes place. This is the plate where the compounds are stored. And in former days, and if you're a scientist in the lab, you know how to transfer liquids from one side to another side. You have to use a pipette. What we're using is acoustic dispensing. So there's an acoustic finger which goes down on the each well, and based on the energy on the acoustic signal, there's a droplet of a certain size, 2.5 nanoliter, released from the lowest solvent, and is shot into the upper one, and then it's touched to it. It's very fast, it's very precise, and the best thing is that it is very, very safe because it's contact free. So there's no risk of carryover from one well to another. So in the end, then you have the miniaturization of your assays. This is just shown here in the back how the plates have been looked 10 years ago. Now it's miniaturized, so you get 20 of those 96-volt plates onto one of those nanocarriers. The final assay volume is as low as 0.24 femtoliters, so it's very low volume. But we go one step further. So we don't test our targets in media, we test our targets in the natural environment. And this is shown here. This is a co-culture of two different types of cells. It's neuronal cells as well as muscle cells. Those muscle cells build after a few days myotubes, so muscle fibers. And then they are linked naturally, we give them some ingredients, to the neurons. And after a few days, they start to contract. So these cells will start contracting, And this is, in effect, we can then relatively easy measure. So this is the newest development to measure as physiological as possible. Even though the assays are miniaturized, but the systems we have to use for testing it is quite large. So this is a picture of my lab. It is, yeah, we have one third of my people are engineers. So we have robotic systems. So this is the acoustic dispensers, the compound libraries in the back of it. There are two robot arms for plate transfer.